for you, we are targeting today's session towards a wide variety of healthcare providers who are involved in maternal health. If you're tuning in because you are someone who is or has experienced a pregnancy, you're also very, very welcome. The graph you see on the screen right now is numbers as of Friday afternoon. We had 1,300 folks registered for this session from around the world, and we're just delighted. We think that that really speaks to the interest in this area and the need for attention. I want to start off this session by finding out a little bit more about those of you who are attending. So I'm going to ask for our first poll question. And as that poll is getting launched, we want to ask you, which of the following best describes you? I'm going to stop sharing my screen. Which of the following best describes you? Would you say that you're a health provider, currently experiencing or have experienced a pregnancy, a policymaker? Oh, that's the wrong poll question. I don't know if we can get another one, if that's possible. Wait for 1 second for the correct poll to be launched. There we go. So which of the following best describes you? Would you say that you're a health provider? You're someone who is currently experiencing or has experienced a pregnancy? Are you a policymaker, a researcher, a student/resident, or other? And if it's other, please feel free to post your answer in the chat. And you can select more than one of these. So if there's multiple identities that you share here today, please let us know. We will give it about another 10 seconds, perhaps. Thank you to all of you who have engaged. There's a lot of you. Another 5 seconds or so. Great. Okay, let's share those results back. So I'm so excited that we have a lot of healthcare providers here joining us, as well as folks who have experienced or are experiencing a pregnancy, some researchers, some students, policymakers. This is really helpful information for our panelists who will be presenting to you today, and I hope that everyone can learn something new. So today, the 4th of September, as many of you may know, is World Sexual Health Day. And so to get us started, I'd like to welcome Dr. Elna Rudolph, the president of the World Association for Sexual Health and a medical doctor and sexologist in South Africa, to say a few words. Elna, it's great to see you. I'll turn the floor over to you.
Thank you, Leanne, and thank you so much to the ladies and gentlemen, so many colleagues and friends that are here today. It is with great pleasure and a profound sense of responsibility that I engage with you today here as the president of the World Association for Sexual Health during this momentous occasion for us, World Sexual Health Day. It's the 14th time that we are actually celebrating World Sexual Health Day, and this year under the theme consent. The World Association of Sexual Health is the official custodian of World Sexual Health Day, and I extend my heartfelt gratitude to WHO and specifically HRP for inviting me to deliver this welcome message today. And under this very important theme that you have chosen, and that is let's talk about sex and maternal health. The theme of consent has a profound connection to not only sexual health, but specifically with maternal health. As a mother of 2 young daughters, I understand this integrate balance very well and how important it is to let these 2 pillars of well-being match and mingle. And as you can imagine, they are both very close to my heart. Let me first emphasize that the right to sexual health is a fundamental human right. It involves the right to make informed decisions about our sexual lives and to access sexual and reproductive health services free from discrimination and coercion. When we talk about consent, it is the cornerstone of this right. It is the critical factor that empowers individuals to make choices about their bodies, relationships, and parenthood. Consent is a thread that is intricately weaved in its way through every aspect of our lives, particularly when it comes to maternal health, pregnancy, and childbirth, or transformative moments in a person's life, as many of you shown that you already know. And it is an essential that every step of this journey is marked by informed and voluntary decisions. Consent in maternal health means respecting a person's autonomy to make choices about their bodies and their birthing process. It means ensuring that expected parents have access to comprehensive information and can make choices that are best suited to their unique circumstances. Unfortunately, that is not the reality for most expectant mothers around the world, as you will hear from the rest of our panelists today. Consent in maternal health extends to the critical issues of safe and respectful childbirth practices. We must ensure that women are treated with dignity, compassion, and respect during childbirth. No one should ever feel coerced or forced into medical procedures or interventions without their informed and voluntary agreement. And this not only safeguards the physical well being of mothers, but also their emotional and psychological health. Moreover, the impact of consent transcends to individuals and extends to the well-being of families and communities. It's not only about that individual mother. When the individuals are empowered to make decisions about their sexual and reproductive health, it leads to healthier families and eventually more robust communities and societies. It promotes gender equality, reduces maternal mortality, and ensures that every child is born into an environment where it is loved and wanted. On this World Sexual Health Day, let us commit ourselves to fostering a world where consent is not just a word, but a lived reality. Let us work together to ensure that every person, regardless of their gender or background, can exercise their right to sexual health and maternal health. It's a responsibility that falls upon each one of us as individuals, as communities, and as global citizens. In closing, I would like to express my gratitude again to the HRP and WHO for its unwavering commitment to sexual health and to reproductive health and maternal well-being. We, as the World Association for Sexual Health, are proud to be in official working relations with WHO and all that we have accomplished together already. Your tireless efforts have saved countless lives. You know, when you are a doctor and you are into saving lives, what you guys are doing is actually really saving lives, and also sex lives on top of that. And it has improved the health and dignity of countless mothers and families around the world. Let us remember that consent is not just a concept, it's the foundation upon which we can build a healthier and more equitable world. Together, we can make this world a reality. We have overcome slavery and apartheid. With me being from South Africa, I've seen it, and we can do this too. Thank you, and let us begin this important dialogue. Let's talk about sex and maternal health. Back to you, Leanne.
Thank you so much, Elna, and thank you for your leadership of WAS and also for reminding us that today's theme of World Sexual Health Day is consent. I think you gave a very concrete example of just how relevant that is across our lives. So thank you so much, and thank you for being here. Now, before we introduce our panel, and I would like to pose a second poll question to those of you who are tuning in. So let me see if I can request another poll question to be launched on sexual health training. Goes up. And thank you to those of you who alerted us that the chat was not working. It is online right now, and it's such a pleasure to see so many of you tuning in from around the world. Thank you for joining us. So if I can get our second poll question to be launched. We know that sexual health training is essential for equipping health workers with the knowledge required to effectively discuss sexuality with patients. So our question for you is, in your experience, how comfortable do you feel discussing sex and sexuality with your patients, or if you yourself have been a patient, with your health provider? And you can choose from the top: very comfortable, comfortable, it varies, uncomfortable, very uncomfortable, or if it's not relevant, I don't discuss this topic with my patients or health providers. So we'll give you maybe about 10 seconds or so to respond. There we go. The poll is ended, and let's go ahead and share those results. Oh, this is very interesting. So we had about 147 people respond, and about a third of you say that you're very comfortable. A quarter say you're comfortable. Another 30% or so say it varies. And then folks express some discomfort. So I hope it's great. I would love to see in the chat your strategies for discussing sexual health and sexuality. So please feel free to share those as our panel kicks off. And to start this panel, let's go first to Dr. Faysal Al-Kak, who's an obstetrician and gynecologist and director of the Women Integrated Sexual Health, or WISH program at the American University of Beirut Medical Center in Lebanon. Faysal, it's lovely to see you. Your talk is entitled Sexual Health and Function Across Pregnancy and Postpartum, the New Reality. I'll turn it over to you.
Thank you, Leanne. Hello, everyone. I'm very glad being here celebrating with all of you the World Sexual Health Day. So happy day to everyone. As Leanne said, I'll be talking to on the sexual health across pregnancy and postpartum, something very important, something that a lot of people believe, and I'm one of them, is neglected. I think you see my slides.
Yep.
So I'm gonna go over in the time I have over the essentials of this issue. Child sexual health remains very important in the woman's health across her lifespan, and influenced by many factors. Part of this is the sexual health in pregnancy, childbirth, and postpartum, with all its contributing factors. In a recent study, 91% of the pregnant women met the cutoff point for sexual dysfunction. And that's alarming, knowing that if you have more than 200 million deliveries per year, will be like 125 million will have at least one sexual problem that we as providers have to be dealing with and responsible for. And to prove it, this is a paper from the Australian Journal of Primary Healthcare showing that only 25% of the sexual health was asked by nurses, and only 13% of the providers did ask about sexual health in the pregnancy. If you look in different recent articles from different regions, they all agree that pregnancy, as the pregnancy progresses, the sexual function is compromised, the sexual activity decreases, and the sexual behavior changes. If you look at the first trimester, because of hormonal, somatic, and psychological factors, there is a change in the interest, and there is a change on the 4 domains of the sexual function. In the first trimester, although 45% of women expressed a desire to have sexual intercourse, around 50% of them were still afraid that this will harm the fetus. In the first trimester, there was a decrease in the domains of the female sexual function index and in the frequency of the sexual activity. In the second trimester, the data shows sexual function and the sexual domain activities might increase or decrease. So on one hand, it might improve because you have enough lubrication, hyperemia, and there is vascular changes affecting the genital organs and the oval or body organs. There is a greater self-confidence, and you feel more secure that the pregnancy is doing fine. In the third trimester, there is a lowest level of libido, with the drop in the frequency of the sexual activity and the orgasmic experiences, in addition to the issues related to body image and psychological challenge. In these 2 interesting papers, you can see, looking at the last column, that there is a significant change between the third trimester and the first trimester in terms of the drop in all the domains of the female sexual function, and the interest and the arousal and the orgasmic experience, and also in the pain. They all have dropped significantly from the first to the third trimester, and that needs our attention to discuss. In this paper from the Journal of Sexual Medicine, they have shown that the frequency of the intercourse have dropped. You see, from the before pregnancy in the gray all the way in the dark gray in the third trimester, and the drop was at least 30 to 35%. At the same time, also the desire have dropped from the first trimester to the third trimester, and that was significant. This is one of the recent really big reviews of 56 prospective retrospective studies from the US, showing there is a gradual decline in the vaginal intercourse from the pre-pregnancy all the way to the first and third trimester. There was little change or no change in the non-coital sexual behavior, meaning that if you look at the different positions that are comfortable to the couple, missionary position continued to be dominant from the first to the third trimester, which is really contrary to the recommendation of the American College of OBGYN in 2016 that really recommends to minimize or against the missionary because of the discomfort caused on the gravid uterus and the pregnant mother, but people still needs more education and awareness around this. Of course, we know that all these issues around dropping in the female sexual function domains and also in the frequency of sexual activity are related to the pregnancy changes. In addition, as providers, we have to know that besides all the nausea and vomiting issues and feeling fatigue, there is also the history of infertility, history of previous abortion, emotional stress, the BMI issue, although there is no consensus upon regarding this. There is also the relation with the partner, there is also body exposure, and there is also the mental health condition. All contribute to the level of the sexual function and performance during pregnancy. After delivery, okay, there is also a multifactorial and broad factors contributing to this. Data are inconsistent. There is between 20 and 60% of women reporting dysfunction in the postpartum. And if you look at the reinitiation of the focus, there is up to 17% in the first 6 months postpartum. However, by the 97% will reinitiate their coitus by 7 to 12 months in the postpartum. However, the quality of this, the outcome of this in terms of pleasure, of satisfaction, of course, varies. But this is for the reinitiating of coitus. If you look at the influencing factors based on these two landmark studies, the decrease in the sexual desire is common because of the physical recovery, breastfeeding, fatigue. There is also pain with the sexual activity due to low estrogen level after delivery. There might be local injury or perineal tears. There is also the risk of postpartum depression, couple relation perception, mode of delivery, and of course, if there is breastfeeding. This is a very interesting paper from Australia, looking at a really good number of mothers, showing that 51% continue to report loss of interest in sex at 12 months postpartum, and 33% reports pain. This is another interesting study called the MAMI study from Ireland. Again, there are changes across all these domains that I have mentioned before. But if you look at the 12-month postpartum, only the lack of lubrication and the lack of interest will persist as main problem postpartum that needs our attention. If you look at the biological mechanisms, why is this happening? The main thing, there are the mode of delivery is being considered. There is the severity of the perinatal trauma causing up to 70% pain during intercourse up to 3 months postpartum. And there is also what we call the pudendal neuropathy due to the compression by the fetal head. The severity of the perinatal trauma was really illustrated in this paper from Yale, showing that the largest degree of pain in the postpartum is when you have operative delivery using forceps or vacuum causing perineal tear or injury to the vaginal muscles, followed by the regular delivery without any forceps, followed by cesarean section. If you look at the pudendal neuropathy, You can see on your left-hand side in the A, how the status of the vagina and the nerve supply before, and then during the second stage of labor and delivery, there is total dilatation, the fetal head, the body weight, the process, the intrapartum process of childbirth will be affecting the pudendal nerve, causing pudendal neuropathy, responsible later for reduction and problems with the sexual function and performance. Probably the most common question would be like the mode of delivery. Some people say, you know, cesarean, you do this, there is no pain. Some people say no, normal vaginal delivery, and so on and so forth. The earliest really serious was from Tara Hicks, the midwife, published, and in consensus, there was no agreement upon really a difference between elective cesarean and normal vaginal delivery in relation to sexual function up to 18 months postpartum. Another paper came from the UK. We also published a paper from Lebanon and the Middle East. And all these, in addition to this paper from Australia, have shown, again, inconcluding results. The last paper, this Perinatal childbirth, have shown that there is a significance, if you can look, when it comes to emergency cesarean, forceps use, okay, and the presence of perineal tears. All were contributing to pain as a mode of delivery. Another one from the Journal of Sexual Medicine showing that emergency cesarean and vacuum delivery contribute to pain during sexual activity. In these papers from UK, from Brazil, from Turkey, showing there is no effect of the mode of delivery. So again, it remains inconclusive. This is from GSM, another review of really a good number of papers showing that the light blue is like no effect, dark blue is there is effect, and you can see again the results regarding mode of delivery is inconclusive. This is the latest review, very recent, this year from Greece. 16 eligible studies, 41,500 women, mean age 30 years, spontaneous versus assisted versus cesarean delivery. It concluded that type of delivery appears to be irrelevant. However, moderating factors like subjective experience, perineal trauma, remember, perineal trauma, always, seem to be affecting the sexual function. Another also things we talk about all the time, another procedure, episiotomy. Studies have not yet defined episiotomy as a risk factor for decreased sexual function, contrary to what most of the providers believe. The level of evidence remains unsatisfactory. A very recent Cochrane review have shown no difference in the presence or lack of episiotomy after 6 months postpartum in relation to pain during intercourse. This is the paper I referred to earlier from Australia, again showing that by 12 months, almost all the sexual function will return to normal, except for the issues of lack of interest in sex and also the issue of vaginal lubrication. These are different studies from different, again, regions, including the famous COMAG study from WHO. And this study have shown that maternal morbidity, relation with the partner, breastfeeding, BMI, mental health, and the issue of intimacy, all were contributing factors to reduction of sexual function and also to the space sexual activity and pain during sexual function. All these are tips for the providers to keep in mind for counseling. In conclusion of this, perineal trauma is for sure agreed upon factors, while breastfeeding is also agreed upon factor that impact sexual activity, and that is something to keep in mind. There is a new reality for women that we have to conclude out of this great seminar today, which is the issue that has to do with the perception of women themselves to sexual activity. I'm going to read one of these. See, once I fell pregnant, I had no interest in sex, none whatsoever. I suppose I have lost confidence just knowing that I'm a mom. I don't see myself as sexy anymore because I know that I'm a mom. Those things do not go together. And that's, for me, I think is very, very important. The discordance of sexual desire in month following birth, causing feeling of guilt by the parturian, by the delivering mother, and the failure that they cannot live up to the expectation of the partner in most of the time. And at times, according to this interesting paper, they pretend to have a fake desire and a fake orgasm. As for the interventions that we have as providers, there is the perineal massage, there is also pharmacologic, like estrogen use, there are CBT, various forms of counseling, there is pelvic training. So there is a wide range of interventions that we can provide alone or in consultation with other team members. At the WISH program, we continue to provide advocacy and awareness around pregnancy and sexual health. And at the end, I just want to emphasize what this panel is trying to emphasize is the importance of addressing sexual health across lifespan, and that means across pregnancy and childbirth, that represents a big part of the life of many women around the globe. Whether we are as providers seek more resources, seek training, and get engaged more in counseling and addressing these issues in the woman's life in order to ensure that the pregnant woman, like all the other women, have receiving quality care, and also they deserve that care and that attention. And thank you very much.
Thank you so much, Faysal. And I think your talk has already prompted some interesting discussions in the chat, as well as some of the Q&A. So I'd invite you to take a look at those when you have a moment. Again, for those of you who are participating, if you have a question that you would like Faysal or any one of our panelists to respond, go ahead and put it in the questions and answers section. And of course, share your experiences, as many of you have been doing in the chat. Before we transition to our next speaker, I'm going to ask you to make use of the chat for our third poll question. And the question that we have is, I mean, you heard Faysal's presentation, but in your experience, what are the most common sexual health issues or questions that arise during pregnancy or in the postpartum period? And I'll ask you to please type your answer to this in the chat. For the sake of our interpreters, I'll repeat the question. In your experience, what are the most common sexual health issues or questions that arise during pregnancy or in the postpartum period? And we welcome your sharing those in the chat. I'm seeing a lack of desire postpartum. Absolutely. Body confidence. Pain from episiotomies, dyspareunia. A lot about postpartum pain or fear of postpartum pain. For those in pregnancy, fear of harming the fetus, knowing what kind of sex and sexual positions is safe. Incontinence, body image, lack of desire, misinformation, lack of lubrication, tiredness, exhaustion. A lot of fear of safety, which I hope we can maybe have some time to discuss in the Q&A. Yes, thank you so much for sharing that with us. I think that gives a lot of our panelists a lot of food for thought as well. I think it's a perfect chance to pivot to our next speaker. It is my pleasure to welcome Professor Jacqueline Dunkley-Bent, OBE. Jacqueline is the Chief Midwife of the International Confederation of Midwives and was previously England's first Chief Midwifery Officer. And her talk is entitled Perinatal Pelvic Health. Jacqueline, thank you so much for joining us. Over to you.
Thank you so much, and what a privilege to follow such an eminent speaker. I'm going to continue on this perineal pelvic floor integrity, I'd call it, pelvic floor integrity journey. So first of all, what I will say, my name's Jacqueline Dunkley-Bent, and as you heard, I'm the Chief Midwife for the ICM, International Confederation of Midwives. And so it is our business, it's our collective business to advocate for women in this sexual health space. So just my title slide, and just a few key points really, just reflecting on what we've heard thus far. Pelvic floor dysfunction, of course, it refers to any combination of challenges, and that relates to incontinence, overactive bladder, pelvic organ prolapse, and other such matters. And we know that pelvic floor dysfunction affects some 25 to 30% of women. And of course, it's linked to the number of babies, parity, and linked, of course, to increasing maturity in terms of age. Also, there's some association with a prolonged second stage of labour. But I'm going to talk you through, for some, a refresher, and for some, helpful insights about what we can do about that. So on to the next slide, please. Lovely. So the slide before. Thank you. And I never tire of rehearsing these stats. In today's climate, 2023, 1 in 3 women will experience urinary incontinence within the first year after birth. Up to 3/4 of these women will continue to experience this in the following 12 years after giving birth. 1 in 10 fecal incontinence and 1 in 12 pelvic organ prolapse. And of course, then, if we move to some of our low-income countries and middle-income countries, in some parts of those communities, we know that obstetric anal sphincter injury is a huge challenge and of increasing concern. So we have a challenge and we have a problem. And I'm sure many women will think, well, let's stop hearing the data. What can we do about it? But just a little bit more, if I may. Obstetric fistulas, we know that this remains a significant obstetrical problem, something that can be avoided with good care and support and guidance, knowledge and expertise of the midwives, obstetricians, and of course, empowering women. But each year, 50,000 to 100,000 women worldwide are affected by obstetric fistula. That is astounding. And, just thinking about female genital mutilation, I know that's a separate subject altogether, but we are thinking about sexual health, and there's a whole literature, another whole session on female genital mutilation, when we have estimates of 200 million girls and women alive today that have undergone that mutilation, and what that means to their sexual health and their sexual pleasure. We know the story behind that. A conversation for another lecture, but nonetheless, these are the challenges that we're experiencing today. And before I get on to what are we doing about, onto the next slide. Before I get onto the next slide, before I get on to the things that we can do as health professionals, policy leads, strategists, activists, together to mitigate and ameliorate some of these challenges, let's just have a look at some personal accounts. So you'll see on the screen there, I've chosen an account from a high-income country. These are published data, so permission has already been given because these are published. Emma Crooks, 34, from Barnsley, an amazing woman who I worked with in the UK, in England, when I was advancing policy on mitigating or championing pelvic floor integrity. So Emma Crooks, 34, from Barnsley, experienced life-changing incontinence during pregnancy and after giving birth to both her children, and said, "Having my children is wonderful, but the incontinence I suffered was horrendous, mentally and physically. I was too embarrassed to tell my midwife." That's a moment in time. That's a key point. Too embarrassed to tell my midwife. But I couldn't leave the house because of the pain and inconvenience, and my partner had to take time off work to support me. I had no idea I could get medical help for it. All the adverts for pads on TV made it seem like you just have to put up with it, and this is why I think it's important for all of us, when we see messages that are trying, media messages that are trying to assist with incontinence, we need to step into that space and challenge our continence providers to also include in their narrative, please access a health professional for help. And that's what's missing sometimes with some of our incontinence products. And I have personally intervened in our continence advertising in England over the past few years. Now, I'm going to now move on to the next slide and share with you the story, this really compelling story. This was taken from the Acquire project. Again, this is published, so you can look this up in the public domain. Karima, so this is on the other side, from a high income to a low middle income country. Karima is 30 years old. She has traveled from another district to Kondini Hospital in central Bangladesh, because she heard they are doing fistula repair surgeries at the facility. That was the reason why she went. Kondini is one of 3 private sector hospitals in Bangladesh where the Acquire project is supporting fistula prevention, management and repair. And if there's anybody from that district in this webinar right now, I salute you for the great work that you're doing. But this person's story, Karima got married when she was 15, not uncommon in countries very similar, and became pregnant when she was 18. Her delivery was difficult. She was in labor for 2 days at home under the care of a traditional birth attendant. She was eventually taken to a local hospital where she birthed. But her child did not survive because of the long labor. And I mentioned the association between long labor, obstructed labor sometimes, morbidity, associated with morbidity, that might be a vesicovaginal fistula, or indeed, sadly, a stillbirth, or sometimes, unfortunately, maternal death. Fortunately, she survived. Unfortunately, her baby didn't, and she developed a fistula. And Karima has suffered from both the physical and social, let's not forget the social ramifications of fistula for many years. And, you know, her husband was a great support to her, and the story goes on. But I just wanted to illustrate those 2 sides of the coin. A woman in a high-income country sharing her experiences, and a woman in another country sharing similar but different experiences, because she speaks about the social impact on what she was experiencing. And we can all imagine what that must have felt like. So I'm going to move on to the next slide and maybe focus a little bit now on our clinical practice and what we can do to make a difference, whether we're in clinical practice as a midwife, an obstetrician, a gynecologist, a general practitioner, a policy lead, a strategist. We can all work together to make a difference. And timely antenatal care and truly listening to what women are saying during their antenatal experience, because they may well, if they know the person that is caring for them and feel that they are listening to them. The icing on the cake, of course, would be to have a continuity of care, so that relationship with the woman, then they are more likely to share their real experiences of what's happened before, or indeed their fears and anxieties about what may happen. So an appropriate risk assessment and personalised care that's personalised to the woman, gender diverse person that is receiving care. No matter where we are in the globe, no matter what the health context, there is something about personalised care. Pelvic floor exercise is absolutely significant, borne by the empirical evidence, the research that says, particularly if you undertake Kegel exercises, consisting of tightening and releasing the pelvic floor. For those that aren't familiar with that, just a tiny bit more complex than that. But this is for you now to go away if you're not familiar with this and look this up. This can mitigate long-term challenges if there is mild urinary incontinence. And over the life course, it doesn't matter whether you're pregnant or not. Also, a pelvic floor that has integrity, that women that are doing pelvic floor exercises, this will impact on their sexual pleasure too. We know that over the life course, of course, the pelvic floor is in a hammock shape, as you saw from the previous speaker in those diagrams. And we know that the pelvic floor muscles become more stretched and more loose, and they lose their integrity due to hormonal changes and the ongoing aging process. And that challenges the pelvic floor in terms of its strength and its ability. It can also be challenged, of course, by weight in pregnancy, by a macrosomic baby, so a larger than average baby. And also then, of course, I mentioned vaginal birth, where you have prolonged active pushing during second stage, and so on. And we've heard, you know, if you had a hysterectomy, if you're overweight, if you've got chronic constipation or excessive coughing, then one needs to do pelvic floor exercises. It's a good exercise regardless of the stage of pregnancy, or even during the preconception period, which is even better. Perineal massage, I won't labour the point on this because of time, but please do, if you're not familiar with perineal massage, please do review this really significant intervention that is undertaken from 35 weeks gestation. And the benefits of perineal massage, it means that the chances of perineal tears or trauma will be significantly reduced. And so you can have a look at the literature in that regard. I'll pop some references in the chat once I've finished my talk in this regard. But what does perineal massage do? You can educate women in their families that it prepares the tissue. So massaging increases blood flow, etc. Of course it does, and encourages the skin to stretch and assists, of course, with that stretching during childbirth. It lowers the risk of tearing. It lowers the needs for perineal repair, of course, if you're less likely to tear. And it also helps those with scar tissue and prepares women for birth. But I'll leave you to have a look at that. If you're interested in this, you might be familiar with the fact that natural oils are the best oils to massage the perineum with. And that's like organic sunflower oil, grapeseed, coconut, almond, or olive oil. And for those that aren't happy with oil, just the natural lubricants of the vagina may be your preference. On to the next slide, please. So here now we have the OAC care bundle. I'm sure people are familiar with this. If you're not, then listen carefully. And for those that are joining this webinar that were the authors, the experts that advised on this care bundle, I commend you. Absolutely sterling work. So what is the OAC care bundle, and what does that word actually mean? I'll give you some background. Between 2000 and 2012 in England, the obstetric anal sphincter injury, OAC, obstetric anal sphincter injury, sometimes referred to as 3rd and 4th degree tears. So the rates of OAC increased threefold in England between that time frame, 2000 and 2012. And it wasn't necessarily because of poor practice. There was something more fundamental than that. Tearing is complex, as we know, and it's influenced by use of forceps during second stage, advancing maternal age, as I previously mentioned. And so the OAC care bundle, the obstetric anal sphincter injury care bundle, if used together, can dramatically affect the short and long-term health of women and birthing people. It also affects decisions about future birth. So you can see for yourselves, there are 4 fundamental steps, 4 sets of interventions that are likely to improve outcomes when implemented together. And these 4 elements, as you can see, antenatal information, manual perineal protection, mediolateral episiotomy, when indicated, of course, and recognition and diagnosis of tears. So I'll leave that with you. And of course, there's always further information. On to the next slide, please. I mentioned perineal massage. So this is just a pictorial representation, not brilliant, but nonetheless a pictorial representation of what that might look like. And women doing it on their own, of course, it wouldn't necessarily look like that. But just a few tips there in terms of how this would be undertaken. So I've mentioned some of this already. So on to my last slide, and my last and final slide. What else can we do? This is not just about midwives, obstetricians, gynecologists, women's health physiotherapists, who are the salt of the earth. We have them in the UK. I'm not quite sure how their specialty is spread worldwide, but they are the ones that really assist in this space to ensure perineal integrity. And so this isn't just about us as clinicians undertaking education, trying to mitigate and promote and support pelvic floor integrity. This is also about government. And I'm proud to say that I have been front and centre of a national initiative in England to mitigate, to reduce perineal, the morbidity associated with pelvic floor injury. So what I'm saying is I've been a part of an initiative to try and reduce unwarranted urinary incontinence, fecal incontinence, pelvic organ prolapse. And this started with being able to contribute to the NHS in England has a long-term plan. And a part of that long-term plan, there was a maternity chapter that myself and colleagues wrote and contributed to. And this maternity chapter, one of the points in the chapter was about perineal integrity and pelvic floor health, simply because we were all shocked at those data that says 1 in 3 women will have urinary incontinence, 1 in 10 fecal incontinence, 1 in 12 pelvic organ prolapse. And because this is our time, all of us, this is our time to try and make a difference for now, for the future, because what we do will ripple through generations. And so the NHS long-term plan pledged that tens of thousands of pregnant women and new mums would receive support to treat incontinence and other pelvic floor issues. And what this means is there was funding and experts that sat together and created perineal pelvic floor services across the NHS, so that where a woman had a challenge or a problem, because we shouted about this wasn't something that was hidden. We created clinics, and they're still in pilot form now across England. For those of you that have joined, that are a part of this, as I say, I commend you, I salute you for the great work that you're doing. But nonetheless, these were clinics, and they're in pilot form, and they were set up as a one-stop shop for women with symptoms, urinary fecal flatus, sexual challenges that were related to childbirth and pregnancy. They were brought together, bringing midwives together, specialist doctors and specialist physiotherapists under one roof, so that every woman receiving maternity care in one of these pilot sites that I've just described would have access to these services throughout their pregnancy. And together, the specialists formed this service for these women. And so I'm not going to labour the point further. You can have a look at this work. It's on the NHS England website. It's just one example of a national policy that is driving change in a country where women would be embarrassed to talk about their urinary incontinence and embarrassed to say that they weren't having an intimate relationship with their partner because of the challenges of urinary incontinence, fecal incontinence, not being able, flatus, and other such challenges. So that's a national initiative. So we started with a recap. We went into some of the size of the problem in terms of the statistics. We listened to a narrative from a woman in the West, in a high-income country, and a woman in a low-income country, real issues for both of them. And then we went into what can we do about these things as clinicians, as policy leads, as strategists. And we ended with a national policy. I thank you for listening.
Thank you so much, Jacqueline, and thank you for that beautiful summary at the end and really walking us through from start to finish just how this can be applied and is relevant at so many levels universally around the world. Thank you. We are going to, for the sake of time and to make sure we can hopefully answer a question or two, we're going to move to our final speaker. I would like to welcome Dr. Ibone Olza, a child psychiatrist and co-founder of El Parto es Nuestro, or Birth is Ours, and director of the European Institute of Perinatal Mental Health. Her talk is entitled Understanding and Promoting Sexual and Mental Health During Pregnancy, Labor, and the Postpartum. Ibone, it's a pleasure to have you. Over to you.
Hello, thank you everyone for this invitation. I'm delighted to be here, and I will try to go directly into the topic as we're short on time. I hope I can share my presentation, and I will bring a slightly different point of view in all of these topics. So I wish we can still have some time for a bit of debate. It was a pleasure listening to you, and I'm going to talk about more about the interface between sexual and mental health. And I will specifically make this point. It's kind of obvious, but I think it's important to remember first to understand that pregnancy, birth, and breastfeeding actually are part of our sexual life. And we have to bring this perspective when we talk. And I also like to bring the perspective of the infant. It's also the infant sexual life that will start through the beginning of life. So we have to keep this broad perspective. So I will look briefly at these aspects, and then I will talk about how to promote. And maybe I do already the spoiler by talking about the main point of my talk, which is to prevent trauma and to provide the type of exquisite, very delicate, trauma-sensitive care that every single woman deserves, which necessarily needs to be very individualized and with a human rights perspective. So I think when we talk about pregnancy and about breastfeeding, about birth, first we have to remember these are all processes facilitated by neurohormones. And we have to start talking about oxytocin and about the important role of oxytocin for health and for pleasure. And this is important. And I like to talk about, mention the process of transformation. There is a psychological process, there are brain changes, and there are these universal needs. And remember that Elna already talked about consent, which is a very important, crucial topic. I wish we would only talk about wanted pregnancies, right? But always remember these needs of privacy, respect, intimacy. And I will use, for the rest of the talk, I will use sex language as recommended by Carlene Griebel and colleagues, and acknowledging also there are people who might not identify themselves as women that are pregnant, but I'm going to talk about women. So these researchers from Spain a few years ago already showed us that pregnancy changes our brain, and these are long-lasting changes. And this explains a bit about the psychological process of pregnancy, which is beautiful, and we have to keep it in mind. There's a process, a specific psychological process happening during pregnancy, and it's important to know this for the way we treat pregnant women, because they're going through a process of emotional sensitivity, psychic transparency, and this probably affects in a way that it promotes also creativity. And I think it's very important we health providers promote a positive view. And a positive view starts by deeply understanding and believing that pregnancy is not a disease, and we should avoid excessive medicalization. We should avoid medicalization. And we should be able to think and help women celebrate pregnancy as a healthy process, okay? And we should be very, very careful about how we talk to women. We should never criticize their bodies or their weight. This just a little word, a little comment, but a health provider can have such a negative impact on women's sexual lives. I think we should all be very aware of this and very careful. And we should especially careful with women who've had eating disorders, or more than that, women also who are survivors of sexual abuse. And I bring this in the conversation because we know already that many women who have suffered sexual abuse have not disclosed it. So actually, we should be very careful with any woman who's pregnant to promote positive body image and also to understand the healthy role of pleasure along pregnancy. How do we do this? I think it's very important also, whenever possible, to include their partners in the conversation from pregnancy. And I want to remind that to remember that men also can have hormonal changes if they live close by their pregnant partner. And I think our main role here is to listen, to educate, and a very important thing, to prevent intimate partner violence. And we have to think differently. I was hearing before my colleague Faysal talking about decrease in libido or a decline in sexual desire. This is the classic perspective, but I prefer not to call it decline. I think it's more important to talk about transformation. The woman's sexual desire transforms during pregnancy, and there is an important reason why this happens. Okay, so I think we have to inform, and it's very important again how we name this. Having sex during pregnancy is not harmful, but we know that fear is the main reason for decreasing activity in both women and men, and we have to understand and listen to know where this fear is coming from. And we have a very serious problem with the high risk context. I like to talk about this high-risk context instead of talking about high-risk pregnancy. I think there are many high-risk contexts where women do suffer violence. And we should all be very aware of this. Gender violence, intimate partner violence increases during pregnancy. This is a very serious problem. And all health providers should do universal screening and be very aware of this. And when we face women who are pregnant, who are experiencing intimate partner violence, we need to be very non-judgmental, very compassionate, very confidential, and offer trauma-informed care. And this is very, very important. And sometimes this might present as a complaint about low sexual desire, but in fact, what we have underneath is sexual violence or partner violence. And also remember obstetric violence and medicalization. Many times this takes the form of women blaming. And we also have to be very, very careful. And also with this risk that I already mentioned of re-traumatization for sexual abuse survivors. These are really broad topics, but I think it's very important to keep them in mind. And also all these very difficult situations many pregnant women are in, like migrant women or war situations. And we also have to remember that childbirth is also part of our sexual life. And childbirth comes with a very specific neuroendocrinological process directed by oxytocin, endorphins, catecholamines, which facilitate an altered state of consciousness. And this state is critically sensitive to the environment. And it's very important that all health providers understand this, not to create trauma, but to prevent trauma. And also because the way care is provided, we have a huge impact on women's sexual life after birth. So this has many applications. In some of these papers, we already described them, but I think it's very important that we think of why is this, why birth is actually a neuropsychosocial event. And there is evolutionary reason for this. And when we look at what's happening in the newborn baby, when it comes out of the mother, and we look at his brain and the maternal brain, we find that there's babies are actually born in love, and they're born to love their mothers, and their brains are flooded with oxytocin and with also all these hormones that make this very likely to stay imprinted. So we have to be very aware of this. And think about in these terms, and also help families understand this, help families. This is going to be the first love of the baby. So in this time, in this postpartum time, the newborn will have some basic infant needs that will also impact his or her future sexual health. So we need to understand the biology of the diet, the need for close contact, the need for skin to skin, the need for intimacy, and this is the transformation. Women's sexual libido is now oriented towards the baby, towards having this pleasant interaction, relationship, and breastfeeding is the way to facilitate this, but we can also have this without breastfeeding, which is also important to understand. The key is this sensitive interaction, but we have to think about breastfeeding as an intimate relationship, and desire is going to be different, and it's very important, it's crucial to include dads and partners in the conversation, to listen to them, to hear them, to educate them, to get their support, and it's critically important to support maternal mental health. And for that, we have to change the perspective, and we have to prevent all this trauma that I was talking about. So how do we do this? How do we promote sexual health? Well, as I said already, we have to prevent the trauma. We have to be very careful with the language. We have to understand that this is a sexual part of our lives, and we have to listen to what every woman might need. And this requires compassionate care, non-judgmental. And we have to be, Jacqueline was talking about preventing perinatal trauma. I think what we have to also be very aware of preventing birth trauma. And birth trauma many times is caused by not sensitive care. Any intervention during birth or during pregnancy by health providers can have terrible consequences for women. There are many references there that talk about, for example, vaginal examinations when they are done without consent, or any intervention done without consent can be highly traumatizing and have a terrible impact on sexual life. So this is a human rights issue. I totally encourage all of you to read the United Nations report on a human rights-based approach to mistreatment and violence against women in reproductive health services, with a focus on obstetric violence. It's very clear we need to get there. And so I will finish this. I was really fast, but I hope we can have some time for questions, remembering the quote by the great Sir John Bowlby, "It's in infancy when we learn to love." So actually, all of this is part of our sexual life and our love life. And let's offer this very delicate care that every single woman needs and deserves. Thank you.
Thank you so much, Ibone. That was a beautiful presentation. I appreciate it. And I also appreciate the kind of natural discourse that you introduced in terms of, we started off talking about things from a more medicalized perspective. You brought us to a holistic one. And I think that reflects a lot some of the discussions we've been seeing in the chat of that balance between, pathologizing versus seeing things as an experience, and that I think what you gave us, that idea of seeing this as a transformation, is a lovely way to end this series of presentations. We have very little time for questions, so what I'm going to do is I'm going to ask all three panelists, actually four panelists, because we had Elna as well, to give me a 30-second response, 30 seconds, to a question that we got from, I believe it was Amanda Burgess, who said that they recognize, for having heard from a few speakers, how important personalized care is. But I wonder how providers can do a better job providing personalized care within health systems that do not naturally provide the space for this type of care. And you all have different backgrounds, so I think this is a really lovely way to get each of your perspectives. I will ask you to keep it short, so maybe 30 seconds each. Let's start with Faysal, please.
Thank you. I did part of the answers to this great comment. Well, I think we should learn our minds as providers to take this very seriously and part of the comprehensive care for women, one. And then we have to seek resources, seek training, seek all types of activities that will really build up our skills to do and provide this important, timely, and needed and transformative kind of personalized care that we cannot do without anymore. Thank you.
Thank you so much. Elna, can I go to you next, please?
So in my private world, I am a doctor and I do personalized care. I'm in private practice, so I am absolutely for private care. But as the president of the World Association for Sexual Health, I want to challenge all institutions globally to make individualized care the norm. If we are not going to expect that from institutions, we are never going to get there. I am from South Africa. I realize the boundaries. I realize the massive challenges, but we need to set the expectation for that. And I'm so glad that it was raised here today. Thank you very much.
Ibone, can I go to you?
Thank you. I think a key issue for individualized care starts by actually something as simple as asking every woman, what do you need? And the needs might be totally different, but this is a basic question. What do you need? And understanding there's usually a reason behind every behavior. And sometimes the woman is a survivor of sexual abuse. Sometimes the woman is in fear for some reason that we don't know. Sometimes the woman lost a baby in the previous pregnancy. So what do you need? That's, for me, is the basic question. To offer compassionate care starts by listening and asking, as simple as that. Of course, then we can get more training, but that for me is a very basic respect.
Simple and eloquent. Thank you. And Jacqueline, the last word to you.
Thank you. And I would really refer to continuity of care. So having that same person that sees you, either whether it's your GP, your midwife, you know, if you're having obstetric care, you know, your obstetrician, that continuity of care is really, really significant. You're more likely to disclose information. You're more likely to feel that that person sees you. And I'll press back into and the evidence, of course. So those countries that are struggling with getting people to listen to them about personalized care, there's an evidence base on continuity of care, and there are benefits that will give a return on investment if there is continuity of care. So respectful, kind, passionate care will yield benefits. And so I think that's where I'd stop in terms of my 30-second summary. Thank you.
Thank you. Thank you both. Thank you all for those excellent answers. 4 providers, 4 different answers. Thank you as well for this panel discussion today. As we get ready to close, I would like to invite Professor Pascal Alote, who's Director of the World Health Organization's Department of Sexual and Reproductive Health and Research, which includes the Special Program of Research Development and Research Training in Human Reproduction, or HRP, to join us. Turn on her camera, hopefully, and share her reflections. Pascal, if you're there, over to you.
I am here indeed, but I can't turn on my camera because I'm not allowed to. So you guys would need to do it for me. It says it's locked by the organizers.
That might be something that we can take care of in a quick second.
But you can hear me anyway. You don't have to see
Absolutely.
me. My first comment is, wow. Thank you for having me. Thank you to our fantastic panel of speakers. Thank you for all of those who have tuned in today for this important conversation. I unfortunately came in late, but even then, a number of really powerful messages have come across. Many of the problems are similar, but what is absolutely clear is how deeply personal and unique these issues are. So your closing question, Leanne, was right on point. Even where we know what the solutions are, we seem to have very little baseline understanding to be able to say what works for everyone. So we have to personalize this care. Really having a stronger sense of what works for women, because we have not privileged the importance of women's sexual health beyond the more encompassing question of reproduction. We have to do better. WHO's working definition of sexual health emphasizes a positive and respectful approach to sexuality and sexual relationships, one that cannot be separated from sexual well-being. And yet, for decades, those of us working in maternal health and in sexual and reproductive health and rights more broadly have neglected sexual health. Effectively, it has remained the silent S in SRHR, and we cannot advance SRHR if we do not understand how these letters interact together and separately. So I'm really pleased that today on Sexual Health Day, we're working to bridge this gap. The changes in desire, arousal, body image, gynecological functioning, and relationship dynamics can be difficult to discuss and navigate, as we've heard, with partners and with care providers, both during pregnancy and the postpartum period. And additionally, medical decisions made during labor and childbirth can have long-reaching implications for women's future sexual functioning. And this underscores the importance of comprehensive counseling, appropriate informed consent, and shared decision-making between women and their providers. We cannot promote holistic maternal health services if we cannot speak compassionately and openly about physical and emotional changes that happen throughout and after pregnancy, and their short and long-term effects on our sexual well-being. I'm encouraged by the enthusiasm we've seen for this webinar series. I think we had over 1,000 people register and over 200 who have stayed for the duration. The diversity of folks from the maternal health community, both on the panel and tuning in, speaks to the timeliness and the need for this area of work. At WHO, in our department, HRP, we're committed to strongly supporting health providers and communities to promote comprehensive sexual and reproductive health and well-being. And we will reflect on your feedback and use it to refine and further concretize our future activities. And we look forward to working with you to achieve this. Thank you so much, Leanne, for moderating this webinar, and to Mercedes and colleagues in the Maternal and Perinatal Health Unit, and to the colleagues in the unit on sexual health across the life course in our department. And we look forward to a continuing discussion. Leanne, back to you.
Thank you so much, Pascal. And we are at time, so I will not belabor this, but I just want to send my sincere thanks to Dr. Elna Rudolph, Dr. Faysal, Professor Jacqueline Dunkley-Bent, and Dr. Ibone Olza for their wonderful presentations. You saw that they did attempt to answer many of your questions that were in the Q&A, but we did not get to all of them. So I would like to invite all of you to keep an eye to follow HRP research. We have a second webinar in this series that we are planning that will be in November. That's going to focus exclusively on questions and answers related to this area. So whether you're a provider or someone who is experiencing a pregnancy or has experienced a pregnancy yourself, this will be a much more informal question answer section. If you want to find out when that webinar will be, you can follow HRP Research on Twitter, or X as it's now called, or you can sign up for our newsletter, and I believe the links are in the chat. Thank you to the IBP network, and thank you to our interpreters for